Hi, it's Dr. Centeno, and this is knee level 2, focusing on a MCL injection under ultrasound, medial collateral ligament. So using this injection, this is focused on MCL laxity, partial, non-retracted, and complete non-retracted tears. So the concept is injecting a lax or torn MCL, but one that is not snapped back like a rubber band. MCL anatomy is more complex than you think. There's a superficial MCL, proximal and distal. There's also a POL, or a posterior oblique, that kind of connects this area with the semimembranosus to help actively stabilize valgus forces in flexion. So interesting that there are two parts here. The proximal attachment is the most impacted, and realize that the MPFL travels anterior here to stabilize the patella. So again, just to review, we have the main MCL, we have the posterior oblique portion of the MCL, we have the MPFL that travels forward here, and then the semimembranosus that hooks into the POL. Injection setup, you can see here, is fairly simple. You have the patient on their side. You have prepped the medial side, and this is easiest to do under long axis, but you can also do it under short axis injection as well. Shown here is the long version. And we can see here off to the right that this is the actual joint line. So that's the medial joint line. This is the medial meniscus. You can see here the fibers of the MCL. And then anything really at this level and here higher up is going to be more of the crossing tendons. There are quite a few crossing tendons here. The pes tendons come across here, the semimembranosus, semitendinosus, sartorius, etc. So realize that the needle is inserted long, so you can see the needle here. This is the cortex. You can see here you can see here again the joint line here. So this is an injection below the joint line off on the right, and this off on the left here. This is an injection at around the joint line. On the femoral side here, this is the tibial side here. So we have the tibia femur, and then we have the femoral side down here. This is we're now above the joint line. You can see here a cortical irregularity, which is an area that probably constituted an old tear. So that's an area to really fenestrate more heavily. So when I mentioned cortical irregularities, that's what I'm talking about, meaning a break in that cortex line, which is easily seen under ultrasound. So as far as step-by-step instructions, the patient's positioned with the affected side up, so they're lying on their side. The leg is straight to slightly flexed. The probe is long axis to the MCL and long to the needle as well. You can use a 22 to 27 gauge needle depending on the inject date. Thin patients do just fine with a 27 gauge 1.5. Stouter patients need a 25 gauge 2-inch needle, and you can even use up to a 22 gauge needle. Visualize the tip during the entire course of the injection. This is a fairly simple injection to do. You monitor fluid flow and adjust as needed, meaning you want to both fenestrate and see your injectate spread throughout the tendon. And you move the probe superior to find and inject pathology in the proximal MCL. You want to inject the proximal middle portion over the joint and distal, so you want to make sure you get all three areas as shown. You want to again inject every cortical irregularity right up to bone. And don't forget the posterior extensions, or the POL component, meaning you want to angle posteriorly as well from the portion just above the femur and the joint line. Pitfalls here, be careful for the saphenous neurovascular bundle and infrapatellar branch. Interesting here, you've got the saphenous, as you know, right behind the coming through the pes tendons. So that's something to be concerned about. There's also an infrapatellar branch which heads out just below the patella here. And you can bag either one. I've actually personally had my infrapatellar branch injected, and it's no fun. Again, you should be looking for visible arteries to identify where these small branches live and staying away from those. Well, thanks so much for watching, and there's also another video on LCL under ultrasound, and then level 3 is the next step in this whole series.